in the previous lecture why we use diuretic. The purpose of using diuretic to enhances the excretion of urine, right? So what are the conditions? There could be another question. What are the conditions in which we are required the use of diuretics? So on top, the basic condition, that is the erythematous state in which we are required the excessive excretion of excessive volume, right? So one of the important condition that is due to heart failure, that is pulmonary edema, in which the fluid is accumulated in the lung parenchyma. So in that situation, especially in that situation, we are required the use of powerful diuretic. What do you mean by powerful diuretic? The diuretic that can remove excessive fluid as well as in short period of time. And what we have discussed in the previous lecture, there are different group of diuretics, and among different group of diuretics, which one is the most potent diuretic? Which group? Loop diuretic, right? Because we have done the two important group, thiazide diuretic and loop diuretics, and at the same time what we have covered the different sites where these diuretic produces its activity, right? So thiazide diuretics, because it's going to produce mild excretion, so that is why generally we use thiazide diuretic in mild to moderate hypertension, right? So now the third important group, potassium sparing diuretic. As already we have discussed the different segments of the nephron, proximal convoluted tubule, right, descending loop of Henle, ascending loop of Henle, and especially thick ascending segment of loop of Henle, then distal convoluted tubule, then collecting ducts. So this potassium sparing diuretic, what is the site of action? Basically, these potassium sparing diuretics, they act on collecting ducts, right? So just like the thiazide diuretic, the minimal amount of sodium is reabsorbed in this segment. So if we stop the reabsorption of sodium, so mild diuretic will occur. And why we label loop diuretic as a powerful diuretic, this concept already we have discussed, because around 25 to 30% of the sodium is reabsorbed in the thick ascending limb of loop of Henle. So if we inhibit uh, this reabsorption of sodium, so sodium is going to be accumulated in the thick ascending segment of limb of loop of Henle, and this solute is going to be accumulated, and it will catches water from inside to outside into the lumen. So excessive amount of water can be removed, and so that is why loop diuretic is supposed to be the most powerful diuretic, whereas thiazide and potassium sparing diuretic compare with the loop diuretic are weaker diuretic. Why? Because just 2 to 5% of the sodium is reabsorbed in this segment. So if we inhibit the reabsorption of sodium in this segment, now you can compare a segment where 25% sodium is going to reabsorb, and in another segment 2 to 5%, so less amount of water is going to be excreted out, right? So as the name indicate, potassium sparing diuretic, why we are focusing on this name? Because what we have done in thiazide diuretic and loop diuretic, in both group in both group generally side effects are same, especially in terms of electrolytes. Both diuretic, thiazide and loop diuretics, they are going to produce hypokalemia, they are going to produce hypomagnesemia, they are going to produce hyponatremia. But one difference, and this was the difference that is very important from the exam point of view. One group is going to enhance the excretion of calcium, so it will produce hypocalcemia, and one group is going to prevent the excretion of calcium, rather it going to improve or enhances the reabsorption of calcium, right? So which group is going to enhance excretion of calcium, and which group is going to enhance the reabsorption of calcium? Can you recall which group is going to enhance the excretion of calcium, and which group of thiazide diuretic group is going to enhance the reabsorption of calcium? So loop, okay, loses calcium, that means loop diuretic. Very good. Loop diuretic enhances the excretion of calcium, whereas thiazide diuretic enhances the reabsorption of calcium, right? So is there any clinical importance of knowing this? Yes, because one important point, one important clinical correlation, what we have discussed in our lecture, that there is a case, there is a scenario in which a female, old female lady having a history of osteoporosis, right, weaker bone history, and you are required a diuretic in that female to control her blood pressure. So this is the question that is asked: which diuretic you will prefer in this female? Definitely we are going to prefer thiazide diuretic. Why? Because it prevent the further excretion of calcium, because if you use loop diuretic, it will worsen the condition, because in osteoporosis there is already a problem related to calcium, right? So this is another very important question that is asked in the exam. Now, both are responsible or may cause hypokalemia. So there are some condition in which we cannot afford the hypokalemic status, right, or low level of potassium. Especially this point I am going to discuss, then we will discuss the potassium sparing diuretic in very much detail. So potassium sparing, that means we are just inhibiting the sodium reabsorption or enhances the excretion of water, but we are preventing the excretion of potassium, right? So there is a condition that is called heart failure. In heart failure, we may use, especially in chronic heart failure, we may use a drug that is called cardiac glycosides. And very important example of cardiac glycoside is digoxin. And one of the important problem related to the use of digoxin, that because this digoxin having low therapeutic index, right? So uh, one of the condition that may produce its toxicity, and one of the condition is the hypokalemic state. If there is low level of potassium, it will increases the chances of digitalis toxicity, cardiac glycoside toxicity, or digoxin or digitoxin toxicity, right? So in that situation, we are going to use the potassium sparing diuretic to avoid the toxicity of digoxin, especially if a patient is on digoxin therapy in the treatment of heart failure, right? So potassium sparing diuretics divided into two major groups: aldosterone antagonist, and the second group is the aldosterone independent. This is important. You know, in the collecting duct, there are two important hormones that control the sodium and water balance. One of the secretion is the aldosterone, and normally aldosterone function is what? Normally aldosterone is going to increase the reabsorption of sodium. And you know, where the sodium goes, water automatically will move towards sodium. So aldosterone enhances the reabsorption of sodium as well as water. And the second secretion, that is the ADH, antidiuretic hormone, that also acts on these collecting ducts, right? So antidiuretic hormone, as the name indicate, it prevents the uh, uh, diuretic effect, right? So before discussing this, the importance of aldosterone, uh, we have done the CVS or not? There is a system that is called renin angiotensin aldosterone system, right? There is system that is called renin uh, angiotensin aldosterone system. You know, when this system is going to be activated, especially in, again, in heart failure, right? So this is very important condition, heart failure. If there is a heart failure in which heart is unable to pump the sufficient amount of blood into the systemic circulation, so what will happen? Low amount of blood will reaches the kidney, and in kidney, in the proximal convoluted tubule from the macula densa, renin is released in response to this low blood volume due to ischemia. So what kidney thinks? Okay, there is low volume, so it will releases renin, and renin is responsible to convert angiotensinogen to angiotensin 1, and angiotensin 1 is converted into angiotensin 2. And at the same time, this renin is responsible to enhances the excretion of aldosterone. So if a patient having heart failure, heart is unable to pump the blood, and if it body further reabsorbs the water, it will further increases the blood volume, and heart at the same time is unable to pump the blood. So blood will be accumulated and backflow. So that is why when the blood comes into the uh, left atrium, from left atrium into left ventricle, and from left ventricle into aorta, so heart is unable to pump the blood into the aorta. So back pressure from the left ventricle, again blood is accumulated in the left atrium, and from the left atrium, blood is coming from the lungs. Due to increased hydrostatic pressure, fluid will leak and accumulated in the lung parenchyma, that is called pulmonary edema. So if this renin angiotensin aldosterone system is activated, it will further increases the blood volume. So that is why when a patient comes into the emergency department with heart failure, difficulty in breathing, and sometimes people as pulseless, so even at that time we cannot excrete out that excessive fluid until unless we initially manage or restore the blood pressure by giving digoxin or digitoxin. When the blood pressure is slightly elevated, then we use the powerful loop diuretic to excrete out this accumulated fluid from the lung parenchyma, right? And at the same time, what can we do? We'll have to inhibit this renin angiotensin aldosterone activity. So one of the important group, that is the angiotensin converting enzyme inhibitor. This is one of the group, right? And we have renin inhibitor, right? And we can use this potassium sparing diuretic. right? Especially aldosterone antagonist. Clear? So aldosterone antagonist. Now back to the potassium sparing diuretic. Aldosterone antagonist, aldosterone independent. Aldosterone antagonist, we have very important example is spironolactone, right? And this is one of the drug that is commonly asked drug in the exam. And the second one is the eplerenone. So at least you must remember these two names. What are these drugs? These are potassium sparing diuretic. How it's going to produce its activity? By inhibiting activity of aldosterone, right? And aldosterone independent, that means for these drug activity like triamterene and amiloride, there is no need, or it doesn't matter whether aldosterone is present or not, right? So triamterene, without presence of aldosterone, independently reduces its activity by just blocking sodium channels in the collecting ducts, triamterene and amiloride. Clear? Okay, mechanism of action of this potassium sparing diuretic decreases sodium transport in the collecting tubule. This mechanism already we have discussed. And the group, prototype drug of this group is the spironolactone, and this competitively antagonist for mineralocorticoid receptor. Okay, this spironolactone, that is basically having a steroid in nature, right? Steroid in nature. Uh, so it will spironolactone competitively antagonist for mineralocorticoid receptors. You can see the mechanism on this diagram. This is spironolactone, and aldosterone is also bind with the receptor. So spironolactone prevents aldosterone binding with its aldosterone receptors, right? So prevents aldosterone stimulated increase in sodium transporter expression, right? Triamterene and amiloride, organic bases secreted into lumen by proximal tubule cells and inhibit apical sodium channel. Okay, what are the therapeutic uses? Primary hyperaldosteronism, like in adrenal adenoma, bilateral adrenal hyperplasia, congestive heart failure. This already we have discussed, right? Cirrhosis of liver, right, in which edema is developed. Nephrotic syndrome, in this condition also edema is developed in conjunction with potassium wasting diuretic. That means sometimes we are required the powerful diuretic like loop diuretic, and we know loop diuretic also loses potassium. So in that situation, we can add potassium sparing diuretic along with potassium wasting diuretic, or try to compensate. Side effects, hyperkalemia, okay, because we are going to spare the potassium, prevent the excretion of potassium, so the level of potassium will raise. Okay, this is very important side effect, though it's not a common side effect. Around 10% of the patient having this problem, gynecomastia, enlargement of breast in male. And why this problem occurs? And there is a question that is asked, especially in USMLE exam, related to this scenario: a patient having a drug after congestive heart failure, and after some time it feels that there is enlargement of his breast. So he is very much worried and went to the consultant and telling him about this problem. So his consultant, okay, convince him, okay, there is no problem, this problem is temporary, and this problem is due to the effect of this drug that you are taking, right? So which one of the following drug is responsible uh, for this problem, spironolactone, right? And mm, why this problem occurs? Because already I told you spironolactone having steroid in nature, it may produces anti-androgenic activity. It may produces anti-androgenic activity, and it will enhances the activity of especially estrogen level, right? So this is the reason of enlargement of breast, decrease libido, right? So this is one of the question that is asked in the exam, and this gynecomastia is due to entry and androgenic activity, right? Okay, and another important point. So if that patient develops this problem, what should we do as a physician? So that to avoid this problem, we are recommending eplerenone. We are recommending eplerenone because if we want to avoid this androgenic activity, eplerenone, if we compare with spironolactone, least chances of developing gynecomastia. This you must remember, right? Okay, there is another very interesting point. Okay, there is a condition. There is a condition. There is a condition in which if we use aldosterone antagonists, whether spironolactone and eplerenone, the patient is not going to show the response. And that condition decrease level of, in this condition, deficiency or decrease level of aldosterone. Can you tell me what is that condition? Can you tell me in which condition the use of spironolactone or eplerenone would be inappropriate or ineffective? The use of these drugs would be ineffective. Can you recall a condition in which there is deficiency of aldosterone? Uh, Addison disease. Addison disease, right? Addison disease. So, in that situation, uh, the use of potassium sparing diuretic, especially aldosterone dependent diuretic, would be ineffective. Clear? So, triamterene or amiloride, uh, that that belongs to aldosterone independent group, and especially triamterene may cause megaloblastic anemia, especially in cirrhotic patient, and amiloride increase in blood urea nitrogen, glucose intolerance in diabetes. Now the uh, fourth important group. So in the previous class we discussed the thiazide diuretic, we discussed the loop diuretics, now we have discussed the potassium sparing diuretics. Now the fourth important group is the osmotic diuretic. Before discussing this group, I just want to share the important clinical point related to this group. You know, this group is supposed to be the very important group. In which condition? This diuretic clinically we use especially in case of cerebral edema. Cerebral edema, right? And second important clinical condition, if due to ingestion of toxic substance, poisonous substance, we can use osmotic diuretic to avoid the damage of kidneys, right? But important clinical condition in which we still we are using, or one of the important diuretic important drug option that we use, that is the cerebral edema. And you know, cerebral edema could be due to accident, due to meningitis, due to space occupying lesion, due to infection. So there are certain conditions in which cerebral edema develop, but commonly the cerebral edema after head injury, right? So this osmotic diuretic do not interact with receptors or directly block renal transport. Activity depend on development of osmotic pressure, right? So this is important point. Do not interact with receptors or directly block renal transport. It just produces osmotic pressure, so it will catches the water from inside to outside. And the clinically, which one of the following we use clinically? Isosorbide, glycerol, urea, mannitol. You will find this preparation in emergency kit, right? In emergency department, mannitol, right? Mechanism of action: osmotic diuretics are not reabsorbed, increases osmotic pressure, specifically in the proximal tubule and loop of Henle, right? The main side is the proximal tubule. Prevents passive reabsorption of water. Osmotic force solute in lumen, osmotic force of reabsorb sodium, right? Simple mechanism. Increase water and sodium excretion. Therapeutic uses: drug of choice, non toxic, freely filtered, non reabsorbable, and non metabolized. Administered prophylactically for acute renal failure secondary to trauma to avoid the kidney damage, cardiovascular system disease, surgery, or nephrotoxic drugs. Short treatment of acute glaucoma, increase intraocular pressure, infused to lower intracranial pressure, that is cerebral edema, due to cerebral edema, right? So urea, glycerol, and isosorbide are less efficient. So if you don't remember any example of this group, but you must remember mannitol. Now the last group of diuretic, that is carbonic anhydrase inhibitors. So thiazide, loop, potassium sparing diuretic, osmotic diuretic, and the last one is the carbonic anhydrase inhibitor. Limited use as diuretic. And in the previous lecture, I told you in simple statement which diuretic is supposed to be the most potent, most efficacious diuretic: lobe diuretic. And among five groups, thiazide, loop, potassium sparing, osmotic, and carbonic anhydrase inhibitor. So among the five diuretic, which one is supposed to be the weakest diuretic? Carbonic anhydrase inhibitors. So limited uses as diuretic, and but you must remember the important example of this group is the acetazole amide. Mechanism of action: inhibit carbonic anhydrase in renal proximal tubule cells, right? You can focus on this diagram as well. Carbonic anhydrase, now this is the normal function. Carbonic anhydrase catalyzes formation of bicarbonate and hydrogen from water and carbon dioxide. Clear? So inhibition of carbonic anhydrase decreases hydrogen in the tubule lumen. So less hydrogen for sodium hydrogen exchange. So increase lumen, increase water retention, right? Or increase excretion. So in water retention in the lumen and ultimately excrete out. So therapeutic uses used to treat chronic open angle glaucoma. So basically, generally, this group is supposed to be very important group related to eye problem, related to important eye condition, that is the glaucoma, increase intraocular pressure, right? So, and this, increase intraocular pressure that is called glaucoma, involve two mechanisms. Either this glaucoma develops due to increased production of aqueous humor, and second one is the this increase intraocular pressure due to increased aqueous humor due to impaired drainage or impaired outflow, right? So one of the option could be to improve the outflow, or second important mechanism involved to decrease the production of aqueous humor, right? So aqueous humor has high bicarbonate composition. So because using carbonic anhydrase inhibitor, excessive or increased excretion of bicarbonate. This group can be used in acute mountain sickness, prevention and treatment of metabolic alkalosis, sometimes in epilepsy as adjuvant drug, mostly used in combination with other diuretics in resistant patients, right? So these are all about the diuretic. The most powerful diuretic, lobe diuretic. The reason already we have discussed, because 20 around 25% of the sodium is reabsorbed in the ascending lymph loop of Henle. So if we prevent this reabsorption, so excessive amount of water molecule is going to be excreted out. Okay, so and this is the group that can be used in emergency situation. Loop, we are talking about the loop diuretic, right? Because it produces powerful activity. So in pulmonary, especially in pulmonary edema where difficulty in breathing, so we can improve the patient condition, right? And thiazide group, you know group of first choice in the treatment of mild to moderate hypertension, right? So, why we prefer to use thiazide diuretics in the controlling hypertension? Because if we use loop diuretics, excessive due to excessive loss of fluid, so it may produce hypertension. So, in emergency situation, definitely we can use, because we have to save the life of our patient, right? And a certain condition in which we are using loop diuretics, but normally in mild to moderate situation we use thiazide diuretic. Okay, both diuretics, both group, loop diuretic and thiazide diuretic, produces hypokalemia, hyponatremia. But one difference that you must remember: loop diuretic enhances the excretion of calcium, whereas the thiazide diuretic prevent the excretion of calcium. Potassium sparing diuretic can be divided into aldosterone dependent potassium sparing diuretic or aldosterone independent. Aldosterone antagonist diuretics, we have spironolactone and eplerenone. One of the problem after using spironolactone is due to its anti-androgenic activity is the gynecomastia, enlargement of the male breast, right? So in that situation we can use eplerenone, because if we compare, there is a chance to develop gynecomastia, but the chances are less as compared to spironolactone, right? Then the osmotic diuretic, an important condition, that is the cerebral edema, increased intra cranial pressure due to injury or trauma or space occupying lesion, or after the ingestion of nephrotoxic drug, we can use osmotic diuretic group, and the key example is the mannitol. Then the carbonic anhydrase inhibitor can be used as adjuvant drug in the treatment of epilepsy, along with main anti-epileptic drug, right? Mountain sickness, and especially this group is very having very much importance, especially in the treatment of glaucoma. So this is all about. So thank you very much for being with me.